So welcome to the class, all of you. So I think today we'll discuss a few topics which are very important and not given routinely in your textbooks. Some of the topics we'll discuss from the Nelson only, like this topic, like milk banking, is not given in your textbooks. You may find it difficult to read and understand. So this topic I have taken from Government of India guidelines for comprehensive lactation management center. So in India, you don't just call it as a milk banking. Okay. So what you should use the term as comprehensive lactation management center. Okay. So there is Government of India guidelines that has been released in 2017. So in that, you need not worry about first section. So first section discusses only about need for your milk bank in India and how much deficient are breastfeeding policies and how much children are exclusively breastfed and all these things. So what you should understand before getting into this topic is the best milk for any baby is mother's own milk. So what you get in human milk banking is a donor human milk. Donor human milk is always second best option. Okay. First best option and always the best option to any neonate is mother's own milk, or mom, what you call it as mom, mother's own milk. If mother's own milk is not available, then only we use donor human milk. And after that only, that is pasteurized donor human milk. Whatever milk you get from milk bank is always a pasteurized milk. So pasteurized donor human milk. If that is also not available, third best option is your unpasteurized shared milk from other lactating mothers. Only after that you will get this formula feeds, preterm formula or a term formula, and later only animal milk is the last, and the worst milk is your animal milk. So this is how the order goes. I will share you this entire document. You can read only from section 2. Okay. So the centers where the pasteurization and milk collection is done, it is not just milk bank. We should not use the term milk bank according to Government of India. They are the comprehensive lactation management center. You may get a short notes or a question as a milk bank or human milk bank, or you may get this term comprehensive lactation management center. Okay. So this is the alternative term for milk bank, what you call. So these centers will not only undertake collection and processing and distribution of milk, they will also undertake range of activities, like they promote and support breastfeeding for all newborns, including preterm, low birth weight, sick newborns, through support of breastfeeding by skilled counseling and lactational management through milk donation and also kangaroo mother care. So they will improve the milk production of the mother herself, and they will empower the mother herself to encourage breastfeeding. Not like we have established milk bank so we can donate milk and so we can use more and more donor human milk to the neonates. So that should not be our goal. Okay. So we should be trying to establish exclusive breastfeeding through the support of these comprehensive lactation management center. Okay. So what are the 6 steps that are involved in comprehensive lactation management center? The first step is screening of donors. Then is milk expression and milk collection. Third step is processing of donor human milk. Processing involves 3 sub-steps. That is pre-pasteurization, they will store and they will pool all the milk, and then they will do pasteurization. And after pasteurization, they will test the milk for any contamination and bacteria. Then they will, after testing, whichever milk is contaminated, they will discard it. And uncontaminated milk, they will store it. So they will store this pasteurized, they will freeze it, deep freeze it. And then whenever required, as and when the demand is there, they will take out from the deep freezer and they will dispense the milk. So these are the 6 steps of comprehensive lactational management center or human milk banking. Okay. So this is the flow chart, how the process flow chart about how CLMC for donor milk utilization goes. So first there will be a donor, how the donor is identified and how they are screened, how they are rejected. I will tell you next page. So first you have to counsel regarding the donation, and they have to take an informed consent. If they don't agree, if they don't give consent, do not force them. They disagree, just leave it at that point. And if they agree for it, then you take a history and examination whether they are suffering from any acute disease or a chronic disease. And then you do a simultaneously serological testing for HIV, HBsAg, and HCV is optional testing in India. And you have to also screen for VDRL, syphilis. And if anything is positive, they will not be eligible. If all the serology screening test is negative, then they are eligible for donation. Then you take them for milk donation room. They will express either hand expression or a breast pump expression, and then they will label the container and you will store the milk in the deep freezer. So until some large amount of milk is collected over next 7 days, 10 days, or maybe 1 month, you can deep freeze the milk. Okay, and then after that you will pool this milk, maybe from single mother, or you can pool the donated milk from 3 to 5 mothers. Not more than 5 mothers milk you can pool. Okay, pooling, what is the help of milk pooling is, it will prevent the inequality of protein content or the fat content from the different mothers. So it will bring to a common level. Okay, after that, some centers do pre-pasteurization testing before subjecting the milk to pasteurization. They will test for bacteria and all. What if you do this pre-pasteurization testing, most of your milk will get wasted. So most of the milk will not become fit for pasteurization. You will be discarding most of the milk. So most of the government run public sector milk banks, they don't do pre-pasteurization testing. They will do pasteurization, and after pasteurization, before storage, then they will do post pasteurization. They will send the milk for culture. Only if that milk is positive, they will discard the positive samples. Only the negative samples they will store in the deep freezer. And then as and when the demand comes from the NICU or nursery, they will dispense. We have to write a prescription, just like we order for medicine. In the pharmacy, we have to order such a baby. We have taken consent to give donor human milk, and against this baby, we have to issue the donor human milk. Okay, so this is how the process flow chart occurs. So you have to write what briefly about Comprehensive Lactational Management Center, 6 steps, and the process flow chart. Okay, so how do you screen the mothers? Always you should remember that there should not be any compromise for the own baby's feeding. It is above and over the feeding of her own baby, she has to donate to the milk bank, and it should be voluntary. And you should not give any money to donation. They should not be incentive based to donate milk, and she should fulfill all donor eligibility criteria. And this donation should be done only at health facility. Okay, currently in Indian setup, there is no collection of milk from home, and she cannot bring the milk sample and submit at the milk bank. Only she has to come to the milk bank facility, then only it has to be donated. Whereas in foreign countries, what they do is the mothers collect the milk at home, pumping sessions, and then they will store there in their own freezer. And usually they will only voluntarily come and drop it into the milk bank freezer, or there will be collection team from the milk bank that will go to their home to home and collect the milk from the mothers. So, but that collecting at home is not permitted in Indian settings. Okay. So who are the potential donors? Only those mothers whose babies are in NICU, they can donate the milk. And those babies who are fed only minimal enteral feeds, the milk accumulation can cause breast engorgement, breast abscess, and discomfort to the mother. Those mothers can express their milk frequently, and they store in the milk bank, or they may donate to the milk bank. And those mothers who are in the postnatal wards, cesarean section mothers, or those mothers who are admitted for antibiotic completion, they may donate after 40 to 72 hours. Their milk output will increase, and they may donate because they may develop breast congestion, and they may need to express for relief. Okay. Other things are those mothers who are coming for well baby clinic, the follow-up clinics. They will come after 3 days, or for jaundice visit they come. If they are motivated, they can donate the milk. And sometimes even the hospital staff who are working in the hospital, they are themselves lactating hospital staff. They can aware that there is a milk bank in the hospital. You can encourage such lactating staff to donate milk. Okay. So what are the exclusion criteria? You should know after selecting the donors, who can be the donors. You should examine the breast for any skin lesions, any herpes on the breast, or any lacerations on the nipple, or any sore nipple, any bleeding nipple. You should screen them, physical examination. And after that, you have to ask some questionnaire whether they have any tattoos on the body, there is any organ transplant being done in the last 12 months, any blood transfusions he has received in past 12 months, and alcoholic, tobacco use, or use of e-cigarettes, and any chronic infection, they're all not a donor. Okay. And if they have a sexual partner who is suffering from or at risk of HBV, HCV, HIV, or any other venereal disease or high risk behavior, they are also not a candidate for donating. Okay. So other drugs, if they are using these selectively, vitamins, asthma inhalers, eye drops, and inactivated vaccines, if they have received tetanus, rabies vaccine, these are all not a contraindication. Okay. So what serological test? HIV, HBsAg, VDRL they have to do. Temporary disqualification is only if they are suffering from acute infection, any upper respiratory tract infection, or any UTI, they are receiving antibiotics, or any autoimmune disorder, or any cough for more than 2 weeks, or mastitis or fungal infection, herpes zoster on the nipple area. And these are all temporary contraindications. Okay. And you should tell them that they are only contraindication for donation of milk. It's not that it is a contraindication for self breastfeeding or breastfeeding their own baby. Okay. It is a contraindication for donating the milk. Okay. So that thing you should be clear during donor selection and donor rejection. After that, milk expression, this thing is not much required. There is no need of routine washing with soap over the breast. Only if she takes shower with a plain liquid soap is enough. There is no need to separately clean with antibiotic soap before every expression. It will cause soreness of breast. Okay. And so subsequently, mother will go to collection room. There will be privacy in the collection room. She can hand express or either use a pump to express the milk. So foremilk and hindmilk, both you should take, though it is not that foremilk should be discarded. So, but drip milk, what do you mean by drip milk is, if the mother is feeding the baby on one breast, the other breast will be secreting milk. So that is called the drip milk. So that drip milk is not advisable for collection. Okay, sometimes there will be excessive milk. They will tell that one side they are feeding the baby, the other side the breast will be secreting milk. There will be wetting of clothes and all. So it only shows that there is excess milk production in the mother. So that is called drip milk. They can pump the opposite breast after some time after feeding this baby. So, but that is not that milk. Drip milk should not be collected because of contamination. Okay. So they can do manual expression or expressing breast pump. Okay. So this chapter is not very much useful. So how much minutes they can use? 10 to 15 minutes they can pump. And they should label it like this, which mother, what is the time of pumping, and they can store it. You should not pour from one container to the other container. Whatever container they are using it should be stored in the same container. It should be dated. It should be labeled and put it in a deep freezer. Once some certain amount of milk has accumulated, then they can do pasteurization. Okay. Pasteurization, what they do is from deep freezer, they will thaw the milk. That is, they will shift to the refrigerator overnight. That is from 2 to 4 degrees Celsius. Thawing is 2 to 4 degrees Celsius. Bringing from deep freezer, that is storing is minus 20 degrees. Minus 20 degrees is storing the milk till the pasteurization date comes. Like you can do pasteurization once in 2 weeks or once in 4 weeks, once at least 2 liters or 4 liters or some 8 liters milk is collected. You can there will be fixed pasteurization days, like every third Friday, every fourth Wednesday, like that. The milk banks will have a specific pasteurization days. Okay, and that pasteurization days, what you do is from deep freezer, you will take out for thawing to a normal routine refrigerator, and next day you will do pasteurization. So there are many ways of doing pasteurization. So pasteurization, there are low temperature for long time and high temperature for short time. These are the two methods that are available. So what we follow routinely is low temperature for long time method. That is called holder method. Okay. So holder method, that is you will boil the milk for at 62.5 degrees Celsius. You will take the temperature to 62.5 degrees Celsius, and then they will hold at that temperature for 30 minutes. And then suddenly it is cooled. Okay, suddenly it is cooled. So what will happen when we do like that is, it will minimize the heat damage to the nutrients, and it will provide a thermal shock to the organisms. So organisms are destroyed and the growth of spores is prevented. It will not cause any damage to the nutrients of the milk. Okay. So, and then this is called the holder method. There are other pasteurizing methods also, high temperature for short time and all. Okay. Then there is ultrasonic pasteurization and all. So after pasteurization, you have to label the milk at the date of pasteurization. So after that, you have to send for culture. Okay. So culture media, what media you use is CLED media. You have to use for culturing. And after culture, what you have to analyze the culture. Okay. So this is for the post pasteurized milk and for raw milk. If the raw milk bacterial colony count exceeds 10 power 4 colony count for per ml of for Staphylococcus aureus, you have to discard. And even for pasteurized milk, even 10 colony forming units. It should be very strict criteria for post pasteurization. Even 10 colony forming units per ml is there. You have to discard the milk. Okay, so such stringent criteria after pasteurization, it should be almost a sterile milk. So once you have discarded the contaminant milk, then you have to store the milk at minus 20 degrees Celsius in a deep freezer. And then whenever you are how much duration you have to freeze, you freeze up to 3 months. After pasteurization, you can freeze the milk up to 3 months. So after 3 months, it may get rancid because of lipolysis. Okay, but still you can use it for consumption. Okay, it will taste different. It may taste different, but you can store it up to 6 months also. So, but after 3 months, what happens is it will cause lipolysis and it will have an altered taste. So time duration, if they ask after pasteurization, how much you can store is 6 months. Okay. But ideally it should be used within 3 months. So once the order comes from the nursery or NICU, you send what they will ask for 200 ml for a baby. You send a 200 ml bottle. They will either store in the freezer in the nursery or they will put it in the refrigerator, door or normal refrigerator. It will get thawed. Only after 24 hours they can use it. If they want to rapidly use it, they have to thaw it with a 37 degrees Celsius. Otherwise, slowly it will thaw over 2 to 4 degrees Celsius over 24 hours. Okay. So who are the recipients? So after knowing all the donors and all, so who are the recipients? So how should you dispense the milk? You should follow first in, first out basis. Like that is, the oldest milk should be dispensed first. Okay, whatever milk has been collected 3 months before or 4 months before, that has to be dispatched first. So that's why you should label the batch number. That's how oldest milk should be used first. Okay. And it should be dispersed only after a physician sign of the prescription. And whatever mother's own milk she expresses, that should be used on the same day only. Okay. So same day it should be used. If it is not used, mother's milk is not being used, it should be frozen in the freezer. Okay. If it is in the refrigerator, it should be used in the same day only. If you're stored in the refrigerator, it should be used within 24 hours only. And frozen mother milk can be used for up to 4 to 7 days. Okay. So who are the recipients? Mainly preterm and low birth weight babies. So sick preterm babies who are like NEC and GI surgery, severe IUGR, mothers, newborn not having access to their mother. Mother is sick, she is admitted in an ICU, intubated, or mother death occurs because of PPH or eclampsia, and babies admitted to the unit whose mothers are not available because of different place. She is delivered at different place. Baby is admitted in NICU different place. You can give donor human milk to that babies, and mothers who have lactation failure, and exceptional cases with medical justification. Everything is coming. The mother doesn't want to feed the baby. So in that situation, you can use it. And multiple births, if she is not able to enough feed the both babies or triplets, you can also use it. Okay. So this is also a flow chart, how it is to be given. So again, we can have a revision like there's a donor mother. She comes to a comprehensive lactation management center. Then they screen for it. They send HIV, HBS, AG and all. Then they will checklist all the eligibility. And then she will go to a expression room. There will be curtains and privacy. She will use her breast pump and express it in the container only. That container is stored in the refrigerator. And till some amount of milk is accumulated, 1 liters, 2 liters, or some 1 week, 2 week, then they will take the milk out from the freezer to the refrigerator. Thawing is done. Then all the milk pooling is done. Then pasteurization is done, and post pasteurization testing is done. And only those fit for donation, they are stored again, put back into the freezer, and you will get the prescription from the nursery or NICU. Then they will send the milk to the nursery, and from there they will do thawing, and then the neonate receives the milk. So this is how the process of milk collection. Either you can use this flow chart or the starting flow diagram I have written. Okay, this is only till the this is also till the dispense, and that is till the receival of the neonate. So I think most of this is clear, I think. Any doubt you have this in this milk banking, or any other questions you have been asked during your posting regarding milk banking? Any other question you were asked about milk bank in your Viva or anything, you can ask if I have missed anything in this. About the components of the what happens to the protein, what happens to the immunoglobulins. So all these things, I will share another article which shows. So what happens to the components of donor human milk? Are they same as human milk and all? So you can read a table given in that. Okay, so there will be some loss of post thawing. Again, it can't be refreezed. Once you have brought the milk from the milk bank to give a baby, it has to be used within 24 hours. Okay, whatever comes to the refrigerator, it has to be used within 24 hours. You cannot again refreeze it and use it for a longer time. Once the milk bank gives milk, either put it in your hospital freezer. They will give, for example, for Sunday, there is a Sunday, milk bank is closed. Saturday, we will order the milk for both days, Saturday and Sunday, both day. So one bottle, we will put it in the freezer. We will not thaw it. The other bottle, we will put in the refrigerator. That will be thawing. Okay. So the thawed bottle milk can be used. The freezer one will again put into the refrigerator. From the freezer, we'll shift to the refrigerator tomorrow. Okay. So that thawing milk is for next day. Okay. So after thawing, you cannot be freezed. Okay, defreeze again. CMV screening in currently Indian guidelines, it is not must. Okay, so CMV after pasteurization, CMV will be destroyed. So post pasteurization, CMV will not be viable. Okay. So after you can for CMV positive mother. If the mother is CMV positive, what they do in Western countries, for mother's own milk, they won't give directly to the baby. So they will ask the mother to express milk, and they will pasteurize mother's own milk, and then they will give to the neonate. That is one way of preventing CMV transfer from mother to the baby. Okay. So that they do only for less than 1.5 kg baby, where the transmission rate and the symptomatic baby is high. What I have seen in the milk banks in Norway and all is they only for more than 1.5 kg, they will not do any pasteurization of mother's own milk. Less than 1.5 kg, they will pasteurize. Pasteurization kills the CMV. Okay. It kills most of the viruses. Pasteurization kills most of the viruses. Any other questions you wanted to know? I will share this material after the class. Okay. So after this, I think we can discuss is what we can discuss is MAS, PPHN, and CDH. So these are the three things that can be discussed slightly, maybe in 15-20 minutes. So this is from the Nelson only. So I think most of you have read only the MAS and PPHN I can discuss. Transient tachypnea of newborn, briefly 1 or 2 minutes I'll tell. So transient tachypnea of newborn, if they ask for 2-3 marks, it is a clinical syndrome of self-limited tachypnea. So why this happens is because of delayed clearance of lung fluid. Okay. So though the incidence is underreported, that is 3 to 6 per 1,000 live births, this is one of the most common cause of tachypnea in a newborn. Okay. What is the most common cause of tachypnea in a newborn is transient tachypnea of newborn. So what are the risk factors? One is twin gestation, maternal asthma, late preterm, precipitous delivery, gestational diabetes mellitus, cesarean section delivery without labor. These are the common risk factors. So not necessarily that always only cesarean babies should have transient tachypnea of newborn. Even a precipitous delivery, very short duration of delivery, and even a gestational diabetes baby with a normal delivery, vaginal delivery, can also have transient tachypnea of newborn. Mainly the fluid should be still present in the lung. Okay. So why fluid? What happens to the fluid is lung will be in a secretory phase. All the lung, there will be fluid accumulating throughout gestation. Okay. From the first trimester till the end of late preterm and all, there will be lung will be in secretory phase. Why secretory phase is required? Because of the lung growth. more there is lung fluid, there will be more branching, more lung growth will be happening. And lung fluid also contributes to the amniotic fluid also. So there will be transfer of fluid from the lungs to the amniotic fluid, and the amniotic fluid baby will be swallowing, that will be coming into the lungs. So this will be happening. So the lung has to shift from the secretory phase to the absorptive phase. So what are the channels that are involved in absorptive phases? ENaC channels and sodium potassium ATPase channels. So what they do is they drive the sodium from the fluid, and as the sodium is pumped out, the water also moves out of the alveoli into the interstitium. Okay, so when there is ineffective expression, so why this switch should occur at the time of delivery? There will be hormonal changes or epinephrine production in the baby. So all this hormonal switch will happen few days before delivery, not exactly on the day of delivery. The lung will be prepared for postnatal adaptation few days before delivery only. This expression of these channels, ENaC channels and sodium potassium ATPase channel, will occur few days before delivery itself. And then almost 1/3 of your fluid will be absorbed before the onset of labor only. 1/3 fluid is removed from the baby's lungs before the onset of labor. During the labor, another 1/3 of the fluid is drained from the alveoli. And after delivery, when the baby takes first breath and when positive pressure is created in the alveoli, then the remaining 1/3 of the fluid is removed by the lymphatics. So what we discuss about the all the fluid is drained only after delivery, it is wrong concept. Okay, so 1/3 is before the onset of delivery only, few days before delivery as the baby is preparing. 1/3 is during delivery, and 1/3 is after the baby is born. Okay, this 1/3 fluid which is left, which is not absorbed properly, that may cause your respiratory distress, that may cause decreased pulmonary compliance and impede gas exchange. So this condition, we label it as TTNB. So what happens is there will be tachypnea. Sometimes there may be retraction, grunting, and sometimes there may be cyanosis also. Most of the baby will settle with less than FiO2 of 40%. Sometimes these babies may be sick and require NIV, or even they may require ventilation also. So chest radiograph will usually, chest on auscultation will be usually clear without any crackles or wheeze. Chest radiograph, there will be perihilar prominent infiltrates will be there, or vascular markings you can see. And there will be fluid in the intralobar fissure. Okay, intralobar fissure, there will be fluid, and rarely there may be pleural effusions also. So if you do blood gas, there may be high CO2 retention and acidosis, but rarely it is seen. So usually it will be normal. Okay, chest examination also will be normal. Chest radiograph, usually perihilar pulmonary vascular markings are prominent, and fluid in the intralobar fissures, and sometimes pleural effusion. Okay, so very rarely they may require CPAP or mechanical ventilation. Everything is rarely here. And what is important is usually resolves by 12 to 24 hours. Only it is a diagnosis of exclusion. Usually you cannot prove that it is a TTNB. Only either it can be TTNB or RDS or any other congenital pneumonia. It is very difficult to diagnose at the time when the baby comes into NICU. What recovers very soon is TTNB. What recovers within 3 days or 4 days is maybe your RDS or a congenital pneumonia, or which takes longer time is your congenital pneumonia. So only after the baby is recovered, then only retrospectively we can label it as TTNB only. Okay, so if there are marked respiratory RDS findings like low lung volume, reticulogranular pattern, air bronchograms, then we can definitely tell it as RDS and think of surfactant. Okay, so otherwise we can tell it as TTNB. Treatment is supportive. There is no evidence of use of any furosemide or epinephrine use. So still there is experimental treatment is inhalation albuterol or a salbutamol. Okay, so what it does is it increases the activation and expression of ENaC and sodium potassium ATPase that may help in fluid clearance. So when given early in the course of TTNB, albuterol may improve oxygenation, shorten the duration of oxygen supply, and may expedite recovery. Still, it is in an experimental phase, not a proven treatment. Proven treatment is only supportive. Just give oxygen. If there is more distress, provide CPAP. The baby will recover within 12 to 24 hours. So this is about TTNB. Okay. So next is meconium aspiration. So meconium aspiration is different. Meconium aspiration syndrome is different. Meconium aspiration can be seen in even 10 to 15% of births. Almost 10 to 15% delivery time, you can see meconium stained amniotic liquor. Meconium strained amniotic, all meconium strained amniotic liquor will not lead to meconium aspiration syndrome. So meconium strained amniotic liquor is seen in 10 to 15% of births, and usually it is seen in term and post-term neonates. Okay, meconium aspiration syndrome occurs only in 5% of such infants. Only those 5% out of these 10 to 15%, not like overall 100 births. Okay, only those 10 to 15 whom there was meconium strained amniotic liquor, out of that only 5% will develop meconium MAS. It may be mild MAS, moderate MAS, or severe MAS. Out of that, 30% may require ventilation. Only 3 to 5% will die. Mortality rate is 3 to 5% out of these 10 to 15% of meconium strained amniotic liquor. Okay. So what happens is usually meconium passage will occur after fetal distress. Fetal distress may be because of any other cause, and after that there will be meconium passage will be there. So not invariably in all population. So fetal distress may occur and fetal hypoxia may occur before the passage of meconium. So if we identify the fetal distress and immediately do cesarean section, and if we don't allow the fetal distress to continue for prolonged time, we can prevent this meconium strained amniotic liquor. We can prevent the meconium passage intrauterine, and in turn we can prevent meconium aspiration syndrome. So identifying fetal distress is very important. Okay. So the infants with meconium strain are usually maybe depressed and they may require resuscitation at birth. Okay. And what is the pathophysiology? You should understand the pathophysiology. You should write the flow chart, this flow chart everywhere. This is a standard flow chart. And this is a time tested flow chart. It is there since 1993. There is nothing that has added new to this meconium aspiration syndrome from that time. Okay, this has been followed everywhere. Even if you see neonatology textbooks or a pediatric textbook, this flow chart is there everywhere. So what happens is there will be physiological passage of meconium. Especially when does it occur? In the post-datism. After the term date is over, the baby may pass meconium physiologically itself. The sphincter may open up anal sphincter and baby may pass meconium. Or if there is a fetal compromise, the baby because of hypoxia or a cord compression or anything, the baby may pass meconium. Okay. So any of these two things, it may cause meconium. It may pass meconium. There may be meconium stained amniotic fluid. So baby may aspirate meconium intrauterine, baby may gasp because of hypoxia, baby may have a gasping efforts and we may aspirate meconium, or it may be a postpartum aspiration. Meconium may be present in the oral cavity, trachea and everything. After birth, when you're doing resuscitation and all, if you're not cleaned the trachea, oral cavity properly, baby may aspirate postpartum. So that will lead to your meconium aspiration. Okay, this meconium aspiration, if it is a large quantity, it may cause proximal airway obstruction. If it is a very small meconium bits are there, thin meconium is there, it will go farther into peripheral airway, and this may cause peripheral airway obstruction. Okay, so this proximal airway obstruction, it will cause air trapping and air leaks, or it may result in ventilation difficulty. It may cause hypoxia, hypercapnia, and acidosis, and it may lead to PPHN. Okay. So peripheral airway obstruction, it may be complete obstruction or partial obstruction. Complete obstruction means atelectasis, and it may result in ventilation perfusion mismatch. And again, it will cause hypoxia, hypercapnia, acidosis. If there is a partial obstruction, it will act as a ball valve effect. Air trapping will occur, air leaks will occur. Again, acidosis, hypoxia, hypercapnia. This is the final pathway, and that will lead to PPHN. Okay. Sometimes there may be small amount of thin meconium that baby may aspirated. Initially, no difficulty in ventilating the baby. Just CPAP, baby is doing well. Second day and third day, it may cause inflammation and chemical pneumonitis. Baby may worsen on the second day and a third day, and the baby may have whiteout lung on second day and third day, and that will cause chemical pneumonitis. Again, it will lead to hypoxia, hypercapnia, acidosis, and this will lead to PPHN. Okay, and it is a vicious cycle. PPHN will lead to hypoxia, hypercapnia, acidosis. In turn, it will worsen the PPHN. Again, hypoxia, hypercapnia, acidosis, it will be worsening. Okay, and if there is a continued hypoxia that is occurring in the baby, it has been not monitored, there may be remodeling of the vasculature. The pulmonary vasculature will become hypertrophic, more of smooth muscle cells in the pulmonary vasculature, and that will cause PPHN after birth. Okay, so this is about the flow chart. Okay. So how will be the clinical presentation? So baby may aspirate either intrauterine or with the first breath, baby may aspirate into the lungs. As I told, small airway obstruction, it will result in respiratory distress, tachypnea, retraction, grunting, and cyanosis. And partial obstruction will lead to valvular mechanism, pneumothorax, pneumomediastinum can occur. Chest will be hyper-distended, hyperinflated chest is very common, and usually improves within 72 hours, but may require ventilation also. And it carries very high risk of mortality. As I told, 30% will require ventilation and 3 to 5% mortality. And sometimes tachypnea may persist for days to weeks, sometimes 3 weeks it can occur. Okay. Typical radiograph, what is the X-ray finding is patchy infiltrates, coarse streaking of both lung fields, increased anteroposterior diameter, and hyperinflated chest. How do you say hyperinflated chest? There will be flattening of the diaphragm. Okay. So these are the in chest X-ray findings. Okay. What was the chest X-ray finding in TTNB? So it is a normally inflated lung. There will be there will be fluid in the intralobar fissure and pleural effusion. So that is the X-ray finding of TTNB. Here, what you find in TTNB in MAS is patchy infiltrates. Some areas of hyperinflation, some areas of atelectasis may be there, and coarse streaking will be there of both lung fields, and anteroposterior diameter will be increased and flattening of the diaphragm. Sometimes you may see a normal chest X-ray also, blackout chest, black lung and all, that may suggest pulmonary hypertension in such babies. For example, if there is a chronic hypoxia is there, baby has not aspirated, there is only remodeling of the vasculature, and there may be a PPH. Okay. So this is how the presentation is. Clinical presentation, how the baby aspirates, how the baby clinically presents, and what is the chest X-ray finding. And as I told, ABG, if you do, these are the 3 things. Blood investigations, there may not be sepsis always. If you do ABG, what you get is hypoxia, hypercapnia, acidosis. Okay. So some babies may require only oxygen, some babies may require CPAP, or some babies may require mechanical ventilation. So ventilation strategy, you may see based on the whether it is hyperinflation and all. You may have to keep a lower PEEP like 3 to 4 PEEP, and you may have to keep PIP between 15 to 20, rates around 40 to 50 per minute. TI, you should keep it as a very short TI and a long expiratory time. So we can discuss about the ventilation in different diseases some other time. Okay, so how do you prevent meconium aspiration? As I told, rapid identification of fetal distress and prompt delivery. Okay, if there is a fetal heart rate deceleration, poor beat to beat variability, if immediately it is noted within, baby may pass meconium within next 15 minutes, 20 minutes, and the baby may aspirate in next 2 hours. By the time they are doing section 4 hours, 5 hours late also, baby may have MAS. Okay, so within 15-20 minutes of fetal distress, baby will usually pass meconium. So prompt recognition of fetal distress, early delivery is the what you can prevent meconium aspiration. Okay. Previously, they used to do amnio infusion, that is not working. And sometimes they have done intrapartum. As soon as the baby's head comes out, they have tried suctioning of the baby's mouth and all. That did not reduce the MAS. And sometimes for a floppy baby, that is non-vigorous meconium, they tried to routinely intubate and aspirate the depressed babies. So that has also been discarded now. So no amnio infusion, no suctioning of the baby after the head is out, and no routine suctioning of non-vigorous baby. So none of these will prevent MAS. Okay. So nothing will prevent the adverse outcome, and it is not recommended. All these 3 things are not recommended. Amnio infusion or suctioning of the baby once the head is out, or routine intubation and aspiration in non-vigorous babies. All these 3 are out. So what is the treatment is supportive. There is no proven treatment for meconium. Just give respiratory support till the distress settles. Sometimes severe baby, only proven therapy is surfactant can be given. Meconium itself prevents the surfactant. It may cause surfactant inactivation. Alveoli, the meconium in the alveoli will cause surfactant inactivation. So surfactant, some may have used surfactant lung lavage also. Some may have just given surfactant like your RDS. They have given surfactant. Okay, so in INO and all is not useful. As I told, administration of exogenous surfactant under INO with only severe MAS and pulmonary hypertension, that has prevented the baby from going for ECMO. Okay, use of INO and surfactant, it has prevented severe MAS baby going into an ECMO. Okay. And what happens in severe MAS is there will be PPHN, which has to be managed with which baby may require high frequency ventilation or ECMO. So if the baby is refractory to conventional ventilation, you have to use high frequency ventilation and ECMO. So prognosis, as I told, 3 to 5% mortality is there. So recent decades, because of improvement in obstetric practices and neonatal care practices, the mortality is very low. And after baby survives, there may be residual lung problems like hyperinflation, wheezing, persistent cough. They may present up to 5 to 10 years and all. Okay. If there is ultimate prognosis of the baby, neurodevelopmental outcome, all these things depend on whether the baby received ECMO and all, or the baby had asphyxia and all. Associated problems like pulmonary hypertension is there. So all these things will decide the prognosis, not just meconium aspiration. Just because meconium aspiration has happened, baby has stayed in NICU, it doesn't mean that baby has a poor neurological outcome. Okay. So this is about meconium aspiration syndrome. Any doubt you can ask. Then is PPHN. So PPHN usually occurs in term and post-term infants very commonly. It also can occur in preterm babies also. Preterm babies also can present with PPHN. Okay. So what are the predisposing factors? The predisposing factors are birth asphyxia, meconium aspiration syndrome, sepsis, pneumonia, respiratory distress syndrome, hypoglycemia, polycythemia, maternal use of NSAIDs, and these NSAIDs can cause in utero constriction of your patent ductus arteriosus (PDA), and maternal use of SSRI and pulmonary hypoplasia because of diaphragmatic hernia or chronic amniotic fluid leak. The amniotic fluid has leaked from 24 weeks, 26 weeks. There is a chronic leak, and there is a oligohydramnios or because of some renal issue, and or there is a pleural effusion. All these things that has prevented that has caused pulmonary hypoplasia. Pulmonary hypoplasia will be associated with pulmonary vascular hypoplasia also. Okay. So these are the predisposing factors. Usual age attained is term and post term, and preterms also can be seen. Okay. So some genetic etiology also has been noted based on the polymorphisms of the carbamyl phosphate synthase gene has been identified that causes defective NO production, nitric oxide production. So what is the incidence of PPHN? 1 in 500 to 1500 live births. Though there is wide variation, we see almost 3 to 5 in 100 babies, we may see PPHN. Okay. So what happens in, again, PPHN is hypoxia, hypercapnia, and acidosis. Okay. So regardless of the etiology, there will be profound hypoxemia, there will be right to left shunting, and there may be normal or elevated CO2. So these are the three things that are seen in PPHN. Okay. So pathophysiology, what happens is in the intrauterine, there will be increased pulmonary vascular resistance. So there will be persistence of fetal circulatory pattern. The fetal circulatory pattern is right to left. So why right to left is present in the fetal circulation? Mainly to supply the oxygenated blood to the brain, the upper part of the body. Mainly the oxygenated blood, more oxygen should be supplied to the brain. So there will be right to left shunting will be there. So this persistence of this pattern, if it persists after birth also, there will be failure of lowering of this the elevated pulmonary pressure. So it will lead to PPHN. Okay, the fetal pulmonary vascular resistance is usually elevated. Compared to systemic pressure, the pulmonary vascular resistance is more. Okay, this fetal state normally permits shunting of oxygenated blood to the left atrium, and from the left atrium, it bypasses the lungs and passes on to the descending aorta, and that's why more oxygen is given to the brain part compared to the lower part of the body. So after birth, what happens is this pulmonary vascular dilatation will occur, vasodilation will occur. Why this occurs? Because of lung inflation. There will be postnatal rise in PO2 concentration. There will be reduction in PCO2. There will be increase in pH of the blood in the neonate, and there will be a release of some vasoactive substances also. Okay, there will be prostaglandins, and all these things will be enhanced. Thromboxanes and endothelins will all come down. So all these things will result in decreased pulmonary vascular resistance. So the pulmonary vascular resistance will fall down compared to systemic vascular resistance. Right to left shunting stops. So when this neonatal pulmonary vascular resistance increases, one thing, it may be maladaptive. So there may be no adaptation occurring after birth. Why this occurs? because of some acute injury. The lung may be injured because of asphyxia, lung may be injured because of meconium aspiration, lung may be injured because of surfactant deficiency like RDS. So normal vasodilation will not occur after birth. Okay. So even though you are giving oxygenation, sometimes it will take some time for pulmonary vascular resistance to fall. So apart from this is there will be increased pulmonary artery thickness, medial muscle thickness. Because of chronic intrauterine hypoxia, chronic fetal hypoxia, the medial muscle thickness would have increased. So that child may not allow the normal fall in pulmonary vascular resistance as soon as the baby born. So sometimes we know without reason, a term baby, normal delivery, no asphyxia, no any maternal complication for sepsis, absolutely normal your intrauterine NST or CTG curves, the baby will be having respiratory distress. So we don't know with any reason. So it is not even TTNB, normal delivery, no obstructed labor. So why this happens is maybe they might have had a chronic hypoxia that has occurred. The muscle thickness might have improved. That is taking more time for adaptation. That is, baby is not fit for still adaptation. Okay. So that baby may require some oxygen after birth. So later, like 1 or 2 days, it may take for the pulmonary vascular resistance to fall. The other thing is pulmonary hypoplasia, maybe because of diaphragmatic hernia or due to low amniotic fluid or a cystic dysplastic kidney disease, there may be pulmonary hypoplasia. And the last pathophysiology for pulmonary hypertension is obstructive type of pulmonary hypertension. So this obstructive type usually occurs in either TAPVC or a polycythemia or any other diffuse developmental disorder of lung development. So this lung development itself is acinar development itself is abnormal. So these are the 4 pathophysiologies of pulmonary hypertension. One is maladaptive because of acute injury. Then is increased pulmonary artery medial muscle thickness. Third one is pulmonary hypoplasia. Fourth one is obstructive. So all these pathophysiology, what happens is there will be increased pulmonary vascular resistance compared to systemic vascular resistance. So what this causes is pulmonary vascular structural changes will be there, altered reactivity to dilator and the constrictor stimuli. So all this will cause is hypoxia, hypercarbia, and acidosis. Okay. So lung issues may be there. There will be low lung volume, maybe because of RDS or MAS. There will be reduced compliance. Intrapulmonary shunting may be occurring. And what will happen to increase pulmonary vascular resistance is it will cause right ventricular pressure overload. It may cause hypotension, and there may be left ventricular dysfunction also there may be occurring. And what you see is, if you do an echocardiography, you see is increased right to left shunting across PDA and PFO. There may be at PDA or PFO, there may be right to left shunting that may be occurring. So this is about the cardiopulmonary interaction that will be occurring in a PPH baby. All these things can be occurring in a baby. Okay. So what are the clinical presentations? So usually manifest within the delivery room only. Baby may continue to require CPAP, continue to require oxygen. But sometimes you shift the baby to the mother side and baby may develop distress within the first 12 hours after birth. The baby may be brought from a postnatal ward with respiratory distress. And sometimes baby that is related to polycythemia or hypoglycemia and all, you may see severe cyanosis. Baby may come from postnatal ward with the severe cyanosis. Okay. And initially some babies may respiratory distress may be minimal. Okay. But those babies with meconium aspiration, diaphragmatic hernia and all, they may exhibit grunting, flaring, retraction, multi-organ dysfunction, shock. These are all very common. Okay. So if there is asphyxia and all, there may be myocardial ischemia, papillary muscle dysfunction, MR, TR, and both left ventricle, right ventricle dysfunction, cardiogenic shock. These all can be seen. It need not cause only pulmonary symptoms. It may cause shock and tissue perfusion abnormality also. Okay. What you see classically is labile hypoxemia. What do you mean by labile hypoxemia is just if you touch the baby, if you move the baby cries or winces, suddenly the saturation will drop from 95 to 75%, and there will be wide pulse pressure will be there, and suddenly the baby will collapse. So all these things are seen. Chest X-ray in PPHN depends on the underlying cause. If it is because of asphyxia and all, or an idiopathic PPHN, which will be normal. Whereas if there is pneumonia or diaphragmatic hernia, you can see bowel loops, or you may see parenchymal infiltrates, or MAS is there. There may be hyperinflation, or based on the underlying cause, you may see chest X-ray. So you cannot diagnose the pulmonary hypoplasia with just X-ray. If you see pulmonary, if you're suspecting pulmonary hypoplasia and you expect the lung to be very small or anything in pulmonary hypoplasia, no, it doesn't happen like that. Pulmonary hypoplasia will usually behave like an RDS only. It will be white out lung, normally inflated lung. So you will never be able to identify pulmonary hypoplasia with X-ray. Okay. So how do you diagnose? So history taking is important. And any term baby with respiratory distress and cyanosis, your pulmonary hypertension should be one of the differentials. Okay. So all babies, you should be hypoxemia will be there, and they will initially they may respond to 100% oxygen. They may respond to 100% oxygen, and transiently they may improve with positive pressure ventilation, NIV or a CPAP or anything. So if there is severe distress, it may require ventilation only. Okay. So what you should do is you should screen. So screen with differential oxygen concentration in preductal and postductal saturation. There either saturation difference or a PaO2 difference. So this you can prove with either ABG taking from the right upper limb and the one of the lower limbs. Okay. Or you may see the saturation gap also. If there is more than 5 to 10% difference between the preductal and postductal, it will usually suggest a right to left shunting. So echocardiography is very much helpful. You should rule out any heart disease. What do you see in echocardiography is systolic flattening of the interventricular septum. And if you are to see the right ventricular pressure, you have to calculate the right ventricular pressure, and systemic pressure you can calculate by BP cuff. If the right ventricular pressure approaches the left ventricular systemic pressure, then it means that the pulmonary hypertension is very severe. Okay, moderate to severe. If it crosses, then it is severe, definitely severe. If the right ventricular pressure crosses the systemic pressure, then it is severe pulmonary hypertension. Okay, so what you see is peak velocity of tricuspid valve regurgitation jet that will help in estimating the right ventricular systolic pressure by Bernoulli's formula. If they use 4V square plus you add an aortic your right atrial pressure, then you will get the right ventricular systolic pressure. Okay. And also you have to see the direction of shunt across PDA and across pulmonary, across PFO. If the shunt is right to left, it indicates that there is a PPHN going on. Okay. In advanced cases, you may not always get a right to left shunt. It may be a bidirectional shunting also. Right to left to right can be happening. So if there is shunt across PFO only, there won't be any saturation difference between right limb and the lower limb. Okay. If the shunt is across only PDA, only across ductus arteriosus, then only you will see this difference. Always in PPHN, it doesn't mean that you will not get upper limb, lower limb saturation difference. If it is not there, it doesn't mean that there is no PPHN. Okay. If the shunt is across PFO, then there will be no difference. So what are the differential diagnoses? Always suspect cyanotic heart disease if there is PPHN, especially obstructed TAPVR. And the other things are surfactant deficiency. In a term baby, respiratory distress, cyanosis is happening, PPHN is there, then always suspect some surfactant deficiency syndromes are there. And pulmonary artery thrombosis is there. And any congenital diffuse developmental disorders of acinar lung development. Lung development is only abnormal, like alveolar capillary dysplasia. Suppose the baby is not responding to your PPHN standard measures and it is progressively worsening, and after one week also the pulmonary pressures are not coming down. So such cases you should rule out as alveolar capillary dysplasia. There will be abnormal thickened alveolar septum. There will be abnormal alveolar veins and pulmonary arterioles. And in such conditions, they will never respond. It is a fatal disease and it is a genetic condition. You cannot treat this condition. It only requires lung transplantation. So alveolar capillary dysplasia is uniformly fatal and it requires lung transplantation. Remains the sole experimental therapy, that too not proven therapy. So suppose the baby when goes into ECMO, you have tried to taper ECMO, and after tapering ECMO again the baby worsens. So in that condition, always if the PPHN persists for more than 1 week, what the standard textbook gives is you have to do a lung biopsy. Okay. If the PPHN persists for more than 1 week, it is not coming down, then you have to do a lung biopsy at the end of 1 week. You have to rule out this alveolar capillary dysplasia. Okay. Rest all other things like MAS, birth asphyxia, RDS, all other things, usually it will come down by 1 week. If it is persisting for more than 1 week, you should suspect any underlying alveolar capillary dysplasia. Treatment is always the underlying condition you should correct. If there is hypoglycemia, treat it. If there is polycythemia, do a partial exchange. And Response to therapy is usually you cannot predict PPHN will become all right or not, and it is usually complicated by the drugs, side effects of drugs you use here. So initially only oxygen is to be started, and if there is any acidosis less than 7 pH or if there is hypotension, correct it. What you should do is optimization of ventilation. First and foremost thing is optimization of ventilation. Okay. Previously, what they used to do is they used to hyperventilate. PaCO2 they want to remove. They used to do hyperventilation, and they used to give soda bicarb to cause alkalinization so that they thought PPHN will come down. Currently, it is outphased. There is no role. Infants with PPHN are managed without hyperventilation or alkalinization. There is no role of routine alkalinization or hyperventilation. Okay. What you should follow currently is gentle ventilation, normocarbia or permissive hypercarbia, and you should avoid hypoxemia. So these are the things that has to be followed. Okay. So if you are not able to maintain ventilation properly, then you can use mild sedation, and paralytic agents should not be used, because if you use paralytic agents like vecuronium and all, it causes atelectasis and ventilation perfusion mismatch. Muscle relaxants promote atelectasis of the dependent lung regions, and it may cause ventilation perfusion mismatch. Next is inotropic therapy may be required. Sometimes dopamine or dobutamine you can use, and milrinone if there is left ventricular contractility. And if the baby is refractory to this inotropic therapy, then you may have to use hydrocort also. The cardiac might have desensitized because of adrenal insufficiency. You may have to use hydrocortisone. Just like any other shock, if there is hypotension, you have to manage in PPHN. And then is inhaled nitric oxide has a role. You have to start at 20 ppm. So it reduces the need for ECMO. So most newborns will require INO for less than 5 days. Once the baby is stable for 24 hours on INO, you can start tapering. Okay. If the baby is not responding to INO and all, prolonged dependency of INO is there more than 1 week and all, then as I told, you should suspect lung hypoplasia or alveolo-capillary dysplasia. So these are the things you should suspect if there is prolonged dependency is there. Okay. So once the FiO2 requirement comes down less than 0.6, you can taper it to 1 ppm, and you have to slowly taper it. Do not stop abruptly. It can cause rebound pulmonary hypertension. And INO can act like a bridge to ECMO, and sildenafil has been used, not a proven therapy. So sometimes it may work, sometimes it may not work, sildenafil. Not that all babies sildenafil works. Okay. So other things are prostacyclin, IV or inhaled prostacyclin, PGI2 has been tried. Sometimes even bosentan also has been tried. Okay. So still they're all experimental therapy. So in 5 to 10%, what happens is the response to is very poor. So response to INO or mechanical ventilation, everything doesn't work. So they will be benefited by ECMO. So ECMO only 5 to 10% of the babies with PPHN it is required. So what parameters when we should start on ECMO is we have to see 2 parameters. One is oxygenation index, another one is alveolar arterial oxygen gradient. Okay. So alveolar arterial oxygen gradient, if it is more than 620 and OI more than 40 for 8 to 12 hours, so it will predict a high mortality, and this is an indication for ECMO. Okay. So ECMO will improve survival if you put it on a carefully selected patients. Okay. So rest of the things is usually not required. So ECMO usually it is required for less than 10. So when should you go for ECMO? It should be more than 2 kgs. Gestational age should be more than 34 weeks because of high risk of IVH will be there, and it should be a reversible lung disease. So it should be, and the baby should have been gently ventilated. Less than 10 days, the baby should have been ventilated, and there should be no severe asphyxia, no lethal malformation, no genetic condition like trisomies, Bernie Downs phenotype. All those things are all not criteria for, not a candidate for ECMO. So for ECMO, it should be a reversible lung disease, no signs of any bleeding, no asphyxia, no lethal malformation, no baby should have been ventilated for less than 10 days. So you should not have damaged the lungs severely by barotrauma or volute trauma. Then after ECMO also the lung will not recover. So ECMO is just like you maintain the lung and the heart, or only the lung till the lung recovers. You support it acts as a lung machine or a heart lung machine until the heart or the lung recovers. Okay. So if the lung is damaged beyond repair capability by worse ventilation, giving very high pressure, more than 10 days, 15 days, chronically ventilated, it is less chance of recovering, poor response of ECMO. Okay. So long-term prognosis usually depends on whether the baby had an HIE or there was an ECMO requirement. Okay. So outcome of infants with PPHN who are treated with ECMO is also favorable. More than 90% survive in good centers, and 60 to 75% they appear normal at 1.1 to 3.5 years of age. So even requirement of ECMO also has a prognostic effect, or also if the baby has underlying hypoglycemia, symptomatic hypoglycemia, or a seizure was there, or any birth asphyxia was there, all these things decide, not just PPH. Okay. So this is about your meconium aspiration syndrome, and then your PPHN. So next thing is diaphragmatic hernia. So before diaphragmatic hernia, I think somebody asked about development of diaphragm, just one or two diagrams about diaphragm development. If they ask for development of diaphragm, a short note or a 2 marks thing, you can just write the diaphragm originates from these 4 structures. Okay. So what is the time duration when it develops? 5 weeks to 12 weeks. So embryo 5 weeks to 12 weeks is the time when the diaphragm develops. So what all contributes to the formation of diaphragm is, one is pleuroperitoneal fold, then next is septum transversum, and then is esophageal mesentery and the muscle ingrowth from the body wall. Okay. So this is your pleuroperitoneal fold. So there will be 2 pleuroperitoneal fold that come from the lateral wall of the embryo. Okay. So anteriorly septum transversum will come. In between there will be a esophageal mesentery. There will be vessels or the cardiac field that is occurring in this. So growing aorta will also be developed in this esophageal mesentery. All these 3 things will join. So this will form the central tendon part of diaphragm. And the muscle part will be from the mesoderm of the body cavity. The muscle part will ingrow. The red part is what you can see is the muscular ingrowth from the body wall. So these are the 4 contributions of the diaphragm in a fetus. Okay. So pleuroperitoneal fold, the septum transversum, esophageal mesentery, and the myocytes. The muscle ingrowth means the myocytes will come from the mesoderm of the baby, embryonic layer, mesodermal layer of the baby's embryo. All these myocytes will come. Okay. So after this, like a healthy diaphragm will be formed. As I told, the central part, the central tendon is formed by your pleuroperitoneal fold posteriorly, 2 sides, septum transversum anteriorly. Okay. And your esophageal mesentery in the center part. And the muscle ingrowth, the myocytes are the which come from the body, they form the side periphery. Central tendon is by all these 3 structures. Okay. So there will be multiple openings in this diaphragm, that is not required. So this is how the AP view of the diaphragm you usually see. It will be, if you see in the lateral view, it will be usually a inverted J shaped. The diaphragm will be inverted J shaped. The anterior part will be high, and the posterior part will go down up to the L2 also. The attachment will extend up to L2 also. There will be various opening at various level, T8, T10, T12. 12 is aorta, this is esophagus, this is your inferior vena cava. 8 is inferior vena cava. This is all your first year MBBS diagrams. Okay. So if you are suspecting any like eventration or hernia and all, it is very important to look for both AP view and lateral view. Okay. So there will be posterior hernia. So if you check a lateral view, you can get beautifully the diaphragm can be seen beautifully. Okay. This is your inferior view. And what happens in an X-ray? So what happens in an X-ray? How do you identify diaphragm? Is the right diaphragm is usually 1.5 to 2.5 centimeter higher than the left. Okay. Sometimes it may be normal level also. If in some population, it may be even at normal level also. Okay. So the superior aspect of the diaphragm, you can see better in the frontal views, frontal and the lateral views. The inferior borders will blend with the abdominal viscera beneath. Okay. So this is how you can see the diaphragm in the frontal view and the lateral view. Frontal view, you see the right side of the diaphragm level is around 1 to 1.5 centimeters higher than the left hemidiaphragm. And in the lateral view, see the anteriorly, the upper border of diaphragm is here, and the posterior border goes down, down, down. Okay, the posterior border is obscured with the abdominal viscera. The anterior border is obscured with the thoracic viscera, like heart and the vessels. Okay, the anterior border is obscured here. The posterior border is obscured with the abdominal viscera. So if this level goes up, like there is a ballooning or anything, there may be eventration. Okay, so I hope this much is clear. So 4 structures you remember. So CDH, what do you mean by diaphragmatic hernia? Diaphragmatic hernia can be acquired or a congenital. Acquired maybe after trauma. So usually congenital, it is because of there is a gap between any of these structures, as I told, so pleuroperitoneal fold or septum transversum or esophageal mesentery. If they fail to join each other, if they fail to join each other, there may be gap between them. So then that's when your diaphragmatic hernia occurs. Okay. So usually 5 to 12 weeks it occurs, and it is diagnosed mainly after 18 to 20 weeks. The later the diagnosis is there, better is the prognosis. Early is the identification of diaphragmatic hernia, bad is the prognosis. Okay. So the symptoms and prognosis usually depend on the location of defect. So it may be the defect can be any of those openings, esophageal opening, aortic opening, or inferior vena cava opening. Any of these openings, there may be defect. If there is esophageal opening, it is called hiatal hernia, or paraesophageal, that is adjacent to esophageal, that is called paraesophageal hernia. If it is retrosternal, anteriorly it is called Morgagni's hernia. Posteriorly it is called Bochdalek hernia. Back or behind is Bochdalek hernia. Okay, M for munde or front, it is called Morgagni's hernia. Okay, so most common hernia is Bochdalek hernia. That is posteriorly it occurs, and most common side is left side. So Bochdalek is also 90%, left side is also 90%. It is most common. Okay, Morgagni is just 2 to 6%. Morgagni is just behind sternum. Okay, and size of the defect is highly variable. Small hole it can be there, or complete hemidiaphragm may be gone. There may be no muscle. There may be one side may be defect total. Okay. So Western population survival is around 70%, but more than 80% in some centers. In India, it is roughly 30 to 40% is the survival based on the series from AIMS and all. Okay. So why we are worried about diaphragmatic hernia is it usually causes pressure effect on the lungs, and it was earlier thought that the pressure effect on the lung, it causes pulmonary hypoplasia, but it is not the thing. So lung hypoplasia and diaphragmatic hernia may occur simultaneously, or lung hypoplasia may even occur before the diaphragmatic hernia at all. Okay, so sometimes, for example, there is left-sided diaphragmatic hernia. There may be hypoplasia of the right lung also. So these are all genetic etiologies. So this is not the how it is what the traditional teaching is done. The diaphragmatic hernia, there will be always lung hypoplasia. It is not like that. Sometimes there may be diaphragmatic hernia, but lung is totally normal. Okay. So what happens if there is pulmonary hypoplasia is there will be simplified alveoli, number of bronchioles are very less, and the pathology is abnormal septation maybe there, or the lung would have arrested at the alveolar stage or a canalicular stage. The lung would have arrested. Okay. What you see in the lung is there may be surfactant deficiencies, increased glycogen in the alveoli, and decreased amount of total lung proteins may be there. All will contribute to gas exchange. Diaphragmatic hernia is a separate pathology. Pulmonary hypoplasia coexisting is a separate pathology. Okay, it doesn't mean that as soon as you correct the diaphragmatic hernia by surgery, the lung will improve. No, it doesn't happen. Okay, the lung hypoplasia is already established. It has to be handled separately. How much is the incidence? 2,000 to 5,000 live births. So if you are a referral center, you may see so many babies, maybe one baby in a month or two baby in a month. Or if there is a separate hospital, you may see one baby in your in a year, or two babies in a year. Depends on where you are sitting. Most common in females. Females affected twice as common in males. And left is most common, as I told, 90%, and the bilateral maybe 5%, and Morgagni, that is right, pre-sternal, just retrosternal is your another 5 to 6%. Okay, and most cases are usually sporadic. Familial cases are also being reported, and 30% cases there may be other anomalies. So other anomalies like esophageal atresia, omphalocele, associated cardiovascular lesions. So what are the syndromes that are associated with CDH? Is your trisomy 13, 18, 21, Fryne syndrome, Brachman-Delac syndrome, Pallister-Killian, and Turner's. If you remember 3-4 syndromes, that is enough. Muchever you will be able to recall, it's okay. So it may be sporadic, or it may be a syndromic or a genetic cause. Okay. So congenital, left side common, posteriorly common 90%. Okay. Morgagni is 2 to 6%. Survival rate is more than 70% overall, more than 80% in good centers. In India, it is 30 to 50%. And pathophysiology, it will cause may cause pulmonary hypoplasia, or there may be a associated pulmonary hypoplasia also. Okay. So incidence is 1 in 2,000 to 5,000 live births. Most cases are sporadic. Familial cases is there. 30% associated with other organ anomalies. What are the syndromes that are associated? 13, 18, 21, Fryne syndrome, Brachman-Delac syndrome, Pallister-Killian, and Turner syndrome. So how do you diagnose this? More than 50% of your CDH will be diagnosed antenatally when you do an anomaly scan between 16 to 24 weeks. And sometimes if you're suspecting any cystic lesion in the lung, you may do a high-speed fetal MRI that will further delineate the lesion. Okay. What are the ultrasound findings? They may suggest like chest mass is there, mediastinal shift is there, or gastric bubble is in the thorax, or liver is in the thorax, or there may be associated hydrops. So what are some of the imaging findings that are prognostic implication that can predict outcome? So one thing is, if the liver is in the chest, that is a bad prognosis. Then they do is observe to expected lung head ratio. So that is, if there is left side CDH, they will measure the lung distance or the lung measurement of the right side, opposite side, normal lung to the head circumference. So they will take there's a chart is there, observe to expected lung head ratio. Then they will based on that there is prognosis. Okay. So definitively there is no you cannot predict the outcome. Okay. After delivery, how it is diagnosed is by chest radiograph, and sometimes imaging, even chest CT may be required in a difficult case to diagnose. If the baby is totally asymptomatic, you see a cystic structure in the lung on an X-ray, and if antenatal scan also they have given doubtful CDH and all, you may have to get a CT after birth to confirm the diagnosis. Okay. It may be other differentials, or it may be eventuation, it may be pulmonary sequestration, it may be cystic adenomatoid malformation. So you will be very skeptical in a asymptomatic baby. Okay. If the antenatal scan, there is definitive diagnosis is there, there is no need for further imaging apart from a X-ray. Okay. So another confirmation is, if you put an OG tube, if the OG tube is going into the stomach, going back into the thorax, or gurgling sound in the thorax, these are all the another confirmatory findings in the postnatal X-ray. Okay. So you should always, if they come for antenatal clinic, you should always look for other anomalies and syndromic finding, and they may require fetal echocardiography and amniocentesis also. Okay. And they should be sent to a referral center. That is, as I told, in utero transfer is the best transfer, as I suspected yesterday. It's not that you should deliver the baby in a center where there is no facility to handle diaphragmatic hernia. So you should refer the baby in utero. What is the symptom? Respiratory distress may occur. It may occur immediately after birth, or there may be a honeymoon period of 48 hours, and after the baby may worsen. Okay. So early the respiratory distress, poor is the prognostic sign. Okay. So baby may present with respiratory distress, tachypnea, grunting, use of accessory muscles, cyanosis. Classically, like the classical finding of scaphoid abdomen with increased anteroposterior chest diameter, gurgling sound in the stomach, and pushed mediastinum towards right side. These are all very classical textbook finding. You may not get in all cases. So very once in a while, you may get this finding like scaphoid abdomen, anteroposterior diameter of the chest is increased, heart is pushed towards the right side, gurgling sound in the chest. So these are all classical textbook findings. And in case presentation, you may get it. Okay. So bowel sounds may be heard in the chest, decreased breath sounds bilaterally, point of maximum cardiac impulse may be displaced away from the side of hernia. And if you pass a chest Rayleigh tube, it will go into the thorax. Okay. These are usually sufficient to confirm the diagnosis. In such cases, classical is there, no further imaging is required. Only in uncertain cases, like only cystic mass, asymptomatic baby doing well, antenatally suspected and doubtful, they have given CDH and other CPAM, then you have to get CT scan in such babies. Okay. Some patients may present beyond neonatal period also. There may be, as I told, small lesion will be there. It may worsen over time, and it may present, like we have seen a couple of babies in last 1 week, 1 month and all, day 13, sometimes 2 months babies we have seen presenting with CDH. Okay. Sometimes they may present even with sudden death also. And there may be incarceration of intestine, ischemia, sepsis, sudden shock they may go in for. Okay. And how do you manage? So at delivery room, you will divide into delivery room management, NICU management, surgical management, and post-surgical management. So these are the 2 things you have to, 4 things you have to write in a management. Okay. So delivery room management is what you should know. So as soon as the baby is born, there should be an experience center and experienced person should be present at the time of delivery. And you should provide appropriate respiratory support. Like if the baby has no distress, don't do intubation and all prophylactically. Okay, if there is distress severe enough that it requires CPAP and all, then don't give CPAP, directly intubate and stabilize the baby. Okay, if there is no just oxygen requirement is there, just because CDH, don't intubate the baby prophylactically. Okay, only if there is respiratory distress severe enough that it requires some positive support, then only you do endotracheal intubation voluntarily, because bag and mask can cause enlargement of stomach and it will further worsen the oxygenation. Okay. Then immediately put a nasogastric tube, decompress. These are the 2 things that has to be done in the labor room. Then immediately shift to the NICU, get an X-ray done, establish your umbilical venous line, umbilical arterial line, preductal arterial line, and achieve only preductal saturation, only 85%. If you achieve, that is enough. Don't try to target 95%, 90, 98% and all. Preductal saturation, only if you achieve 85%, that is enough. That will prevent the volute trauma. So always remember, gentle ventilation, permissive hypercapnia. Okay, this will reduce the lung injury and mortality. Okay, so echocardiography should be done to assess the pulmonary function, lung, right ventricular function, left ventricular function, and need of inotropes. All these things should be done. Routine surfactant is not advised. Okay, they may be surfactant deficient, but surfactant is not frequently used. Okay, it was not proven benefit. Although surfactant is used, no study has proved it to be beneficial in the treatment of CDH. It may precipitate decompensation. So don't give surfactant in a CDH baby. There will be pulmonary hypoplasia. It is not surfactant deficient. The pulmonary hypoplasia will be there. That will not respond to your surfactant therapy very well. Okay, you may even clog the pulmonary alveoli. Already there will be clogging of alveoli. You will surfactant may get stuck in the alveoli. It will prevent further oxygenation and it may decompensate. Okay, so sedation and paralysis may be required to cause ventilation in these babies. So don't always use paralysis and sedation. Only if it is required, then only you use. So conventional versus HFO ventilation, start with conventional. Only if there is PIP requirement of more than 25, you go for HFO ventilation. Always use HFO as a rescue therapy. Don't upfront go for HFO ventilation. Okay, only if there is PIP requirement of more than 25, use HFO as a rescue mode after your PI conventional ventilation fails. Okay, so conventional ventilation also target PaCO2 of less than 65 to 70. Permissive hypercapnia is used. PEEP, you can keep it as just 3 to 5. PIP less than 25. If it is more than 25, go for HFO ventilation. INO can be used in selective cases, and INO is helpful most probably after surgery. Most probably after surgery, INO is more useful. Okay. ECMO is useful, as I told, more than 2 kgs, and ECMO requirement is longer in CDH babies, maybe up to 7 to 14 days. As I told, PPHN baby, they may be just for 5 days, 7 days, you may require ECMO. Whereas in CDH babies, sometimes you may again read ECMO for 7 to 14 days. Okay. And timing of repair is controversial. Some patient wait, some centers, they wait for the recovery. Like if the baby has gone into ECMO, they may wait for the ECMO to be tapered. And sometimes they may repair even on ECMO. Okay. Even on ECMO, they will repair the baby. Okay. Not that it should be repaired immediately on the first day within 2 hours. That should not be done. Baby should be stabilized, always stabilized before repair. Okay. So it is in delivery room management, NICU management, pre-operational stabilization, surgery, and post-surgery. Okay. So what surgery they do? So surgical repair, as I told, most experts will wait at least for 48 hours after stabilization and until the pulmonary hypertension comes down adequately, the lung has been recruited, good lung established, ventilation has been established. So they will always wait till the FiO2 requirement comes down, PIP requirement has come down on conventional ventilation, then only they will take for surgery. Otherwise, an unstable baby with an active PPHN, you will do trauma to the surgery during surgery. You will handle more pain. That will all worsen the PPHN, and baby may go for ECMO after surgery. Okay, that is a bad sign. Okay. So what approach they do? Subcostal approach is advised, and they may use the native diaphragm only. You have to use it to close it. And if the defect is large, then you may have to use the mesh, that is polytetrafluoroethylene mesh they may have to use. And if they use mesh and tightly, if they do, it is high, there is high chance of recurrence because the mesh doesn't grow as the baby grows. Okay. So that's why there is high chance of recurrence. If there is loosely fitted mesh is there, then it is less chance of recurrence because it will allow the growth of diaphragm on the baby. Otherwise, if the mesh stretches as the baby grows, then it will give away and there will be recurrence in the infancy or in the older childhood. Okay. So after surgery also there may be pulmonary hypertension and the baby may require ECMO also after surgery, as I told. Okay. So some of the predictive ultrasound findings or the MRI findings antenatally you should remember. As I told, lung head ratio, if the lung head ratio is less than 1, there will be no survivors. If the lung head ratio is more than 1.4, all babies would usually survive. Okay. What is the second important consideration is liver in the thorax. If there is liver in the thorax, so it is a poor prognostic sign. Previously, as I told, fetal therapy, initially they try to repair CDH intrauterine, but it has not proven benefit. So what they do is in utero tracheal occlusion they do. In those babies where lung head ratio is less than 1 and the liver is in the thorax, they are the candidates for fetoscopic thoracic occlusion. So they will, at 28 weeks, they will occlude it. 27 to 28 weeks, they will do fetoscopic tracheal occlusion, balloon occlusion. They will remove the tracheal balloon at 34 weeks so that the type 2 alveolar cells will mature. First, they will occlude because of lung growth should happen. After removal, there will be alveolar type 2 cell maturity will happen. Okay. And the other thing is MRI derived lung volume. If the MRI derived lung volume is more than 40 ml, more than 90% survive and only 10% need ECMO. If the MRI derived lung volume is less than 20 ml and less than 35% survival and more than 85% need ECMO. Okay. So these are the prognostic things. If they come antenatally with MRI in their hand and ultrasound report showing lung head ratio and all, you can prognosticate the parents. Okay. This is one of the repair they're showing. They're putting a patch here. They're using a mesh and they're putting the patch. And GERD is seen, long-term GERD is more than 50%. So you have to give anti-reflux measures. And intestinal obstruction, volvulus, adhesions, recurrent hernias can occur. 5 to 20% there is recurrence risk of diaphragmatic hernia. Neurocognitive, only if there is ECMO requirement, there is neurocognitive impairment of up to 67% in CDH babies. Okay. So this is about CDH. So anything you wanted to ask about this CDH or anything? So I think lastly only we'll discuss only about management of CAH. Okay. So this has been asked multiple times. So approach to DSD, you can just write the flowchart that is present in the AIMS protocol. So any question is there? Any grades of PPHN on echo? What you see is you grade according to your systemic pressure. Always you compare the pulmonary pressure with the systemic pressure. If the systemic pressure is, if the pulmonary pressure is less than 1/3 to 2/3 of systemic pressure and more than 2/3, less than 1/3 it is mild, 1/3 to 2/3 of your systemic pressure it is moderate, and more than 2/3 of your systemic pressure or equal to systemic pressure it is severe PPHN. Okay. So, so this is one of the recent Indian Pediatrics article where they discuss the CAH. So management of CAH, always you should discuss two things. One is management of CAH crisis and another one is chronic management. Okay. So management of CAH crisis is very important. Adrenal crisis. Most of your babies will come in crisis in the second week of life if you don't do neonatal screening and all. So they may come with CAH crisis. Okay. So one is management of CAH crisis. Another one is a CAH patient. How do you chronically manage them? And the third thing is, how do you prevent the CAH in the next baby? How do you diagnose prenatally? So these are the three headings you have to write when they ask for management of CAH. Okay, not just like you write this table and finish it off, because so you have to discuss this in three things. So what happens in CAH is there will be block in the hormone pathway, adrenal pathway, 21 alpha hydroxylase deficiency, 11 beta deoxynase deficiency, and 17 alpha hydroxylase deficiency. So all these things will block the cortisol and aldosterone production. There will be adrenal insufficiency. Okay, congenital adrenal insufficiency. Okay, cortisol deficiency, aldosterone deficiency, and there is excess of androgens. So there will be excess of androgens will be occurring. So you may get the symptoms of cortisol deficiency, aldosterone deficiency, and you may get the symptoms of hyperandrogenism. So these are the three things that occur. Okay. So how do you manage PPH, CAH in adrenal crises? So what are the clinical findings? Usually second week of life is the presentation. They may present non-specifically, like just like your sepsis, just like your shock, just like your any critical congenital heart disease or any other intracranial hemorrhage. It may present with lethargy, poor feeding, vomiting, abdominal pain, and they may land in shock to the emergency. Okay, so you should have high index of suspicion always when they come in first month of life, and always have a high index of suspicion, especially male babies where you don't have clitoromegaly and hyperpigmentation and all. You may miss this finding. Okay, so you should always, what precipitates your adrenal crisis is any small infection. Usually gastrointestinal illness or a respiratory illness is what that precipitates your adrenal crisis. Okay. So what is your management in emergencies? Airway breathing circulation. You should restore the intravascular volume. So you should put a wide bore cannula, infuse isotonic saline 20 ml per kg over 10 minutes. And if there is shock present, you may still give fluid up to 60 ml per kg. So further fluid replacement, you should be based on your liver palpation, echocardioglymic status of IVC and all. And how much fluid this has to be given. Maintenance fluid is almost 1.5 to 2 times. You should start with half DNS, and always correct hypoglycemia is there. If there is associated hypoglycemia, always treat it. If there is hypoglycemia is there, it should be corrected. And you should start with, if you're suspecting still the shock is refractory, always suspect CAH, and you should give stress dose hydrocortisone. So how much is the stress dose hydrocortisone? 50 to 100 mg per meter square. Okay, starting bolus followed by 6 hourly 50 to 100 mg per meter square per day in 4 divided doses. Okay, so in neonates, what is the load? If you don't know the meter square, if you don't know the body surface area and all, give 25 mg bolus followed by 6 mg every 6 hourly, 6 mg 4 times daily. Okay, so if you blindly want to give any baby, if there is a CAH crisis is there, so 25 mg bolus and 6 mg every 6 hourly you can give. Okay, and you have to continue intravenous route till the baby is fit for oral taking, and you have to correct any what is the electrolyte abnormality that is seen in CAH is, you see hyponatremia and hyperkalemia. So you have to correct that electrolyte abnormality, monitor vitals and your input output, and you have to also monitor the sensorium. And also simultaneously, after the baby is this crisis is over, when you shift to oral therapy from after IV therapy is gone, then you have to add the mineralocorticoid replacement, that is fludrocortisone. So hydrocortisone, during when you're giving stress dose, you don't need a mineralocorticoid. So once that 3 to 4 days it will take for the baby to settle, you give IV 50 to 100 mg per meter square per day. So once the baby shifts from settles, this crisis comes down. So you have to shift to oral hydrocortisone. How much oral hydrocortisone you should give? Should give 15 to 20 mg. You should come down to 15 to 20 mg per meter square per day. So that time you have to add fludrocortisone. Okay. So what is the rationale of starting hydrocortisone 15 to 20 mg per meter square per day is, so physiologically, how much is the endogenous cortisol production is by in all normal individual population, it is 5.7 to 7.4. This is the physiological endogenous cortisol production every day. Okay, so to match this, we give a double dose almost based on the absorption. It may be only 50% absorbed, liver metabolism, all these things they will calculate, and they will give 10 to 15 mg per meter square per day. This is enough for physiological cortisol. Okay, so this much is enough. So what steroid you have to use? Always use hydrocortisone during neonatal age, infancy and all. You don't use a potent steroid like dexamethasone, prednisolone and all. These are reserved only for post-pubertal age. Only for post-pubertal patients, you have to reserve these prednisolone and dexamethasone. Okay, do not use these dexamethasone or prednisolone in CAH patients pre-pubertal. Okay, so what dose they selected is 10 to 15 mg per meter square per day. How much is the stress dose? Stress dose is usually 3 to 5 times the normal dose. Okay, stress dose is 3 to 5 times. That is almost 50 to 75, maybe 50 to 100 is what is given. Okay. So how much you should not give single dose hydrocortisone. Its effect is only for 1.8 to 2 hours. Short half-life, 1.8 to 2 hours. So that's why, and it has an extensive protein binding, and it suppresses the adrenal hormones only for 2 to 4 hours after the dosage. Okay, so that's why it is given at 3 times or 4 times a day. The scheduling is 3. It is divided. The daily doses should be divided into 3 to 4 times a day, and early morning dose should be given as early as possible, like 6 a.m., 5 a.m. The morning dose should be given as early as possible. Okay, to balance the normal physiological cycle of steroids. So it should be early morning dose should be given as early as possible. Okay. So next is, so what should be monitored for a therapy? So how do you suspect when there is congenital adrenal hyperplasia? So you use what levels you use is 17 OHP. 17 OHP is what is usually monitored. Okay. So as I told, how much is the stress dose steroids? It is 3 to 5 times the daily dose. That is 50 to 75 mg per meter square per day. Sometimes even 50 to 100 mg per meter square per day is always suggested. Okay. So if you want to roughly remember a dose, it is 25 mg during infancy and 50 mg in childhood. If you don't have a body surface area, you are struggling to calculate a body surface area in a child, stress dose is 25 mg during infancy and 50 mg during childhood. So fludrocortisone, how much dosage you should give? 50 microgram to 200 microgram. So why you should add fludrocortisone is it will reduce the requirement of your hydrocortisone. So hydrocortisone also has a mineralocorticoid effect, but a higher dose. So if you give fludrocortisone, it will reduce the reduce the dose requirement of hydrocortisone. So fludrocortisone dose may come down. You may start with the minimal dose. You may go into higher dose. Then again, as the child grows, you may decrease the dose of fludrocortisone. So you have to see the electrolytes, see the blood pressure, edema is there, hypokalemia is there. So all these things you have to monitor titrating the fludrocortisone dose. Okay. So for titrating fludrocortisone dose, you should monitor the weight gain, hypokalemia, hypertension, edema. So these are the things that has to be monitored. Fludrocortisone, how frequently you should give? It is only OD dose, once daily. Fludrocortisone should not be divided into 3 to 4 divided doses. Okay, only hydrocortisone should be divided into 3 to 4 divided doses. Fludrocortisone you should give only once daily dose. Okay, so what should be your goal is you have to maintain the 17 OHP levels. So how frequently you should follow? So any child with CAHs, you should follow first 3 months every monthly dose, monthly follow-up, and 3 to 12 months you have to do 3 monthly follow-up. And 12 to 30 months, you have to do 4 monthly follow-up. Okay. So every time what all you should do is in first 3 months, you should only do 17 OHP. So no further other things are required. So after your 3 to 12 monthly follow-up, what you do is 17 OHP. Along with that, you have to see the testosterone levels. Serum androstenedione can be added if there is option is there. You can also see for plasma renin activity and aldosterone is to renin ratio to titrate the fludrocortisone. ACTH is an optional thing. ACTH is not always required. Okay, only if it is feasible, you can get a full panel if they are affordable. Otherwise, 17 OHP is a must. Okay, and when you should take 17 OHP, always prefer morning sample. So your 17 OHP may vary depend on what time you are taking the sample. Always take a morning sample for 17 OHP. But when when the baby comes in crisis, before giving hydrocortisone, always take a hydrocortisone sample of 17 OHP, send to the lab, then only you start on hydrocortisone. Otherwise, if you start on hydrocortisone and fludrocortisone and all, it becomes very difficult. You have to admit the patient for ACTH stimulation test. You have to monitor the baby for again crisis, or you have to wait for another crisis to happen in the infancy. Then only you can take the critical sample. Okay. So these are the how do you follow up? So what should be your important is you have to monitor 17 OHP levels. So what should be your 17 OHP target is? So 17 OHP should be maintained between 5 to 10. So 5 to 10 nanogram per ml. This should be your target. You don't follow the normal values of your age appropriate normal values. Do not follow the age appropriate normal values. If you see age appropriate normal values, your 17 OHP value comes up to be around less than 2, less than 1. Like that, the chart comes, age appropriate value comes. You don't target such. If you want to, if you try to target that 17 OHP levels less than 2 and all, then you will be end up giving high dose hydrocortisone and all. That will cause steroid toxicity. Okay, so the use of consistently timed is very important. It is undesirable to achieve normal age appropriate 17 OHP levels. It is not desired to maintain age appropriate levels. Always maintain only the what is prescribed. Okay, and always try to maintain lower level of testosterone levels. Androstenedione testosterone levels has to be maintained below 20 in a pre-pubertal age. Okay, so after 6 months, you have to monitor this testosterone and all. There will be mini puberty that will be occurring up to 4 to 5 months of age. So there will be a gynecomastia. All these things will be because of mini puberty. Testosterone levels will be high during the first 4 months of age. So that's why it is not advisable to get a testosterone levels here in the starting months. Only after this 3 to 6 months of age, then only you add testosterone to the your panel of follow-up. Okay. So then when you have to subject the child for surgery, so genital surgery, when you have to subject is if there is a female child, your karyotype shows female, and if there is a severely virilized child, severe clitoromegaly and all is there, then you have to subject the child in infancy only. If there is more than Prader 3, staging 3 is there, then always you should do maybe stage surgery. First stage surgery you should always do in infancy. That is what recent guidelines says. Okay, always send to an expert who is involved in these surgeries, and so always do corrective surgery like any vaginoplasty, clitoroplasty and all is there. So always do first stage surgery in infancy. So what they do is gender assignment is another thing that is discussed. So if it is 46XX DSD, usually if it is a classical CAH, 21 alpha hydroxylase deficiency, you may have to end up assigning female gender. Okay, even though it is severely virilized and all, you may get surgery done, good medical therapy, you may control CAH, and it is they may even become fertile also. For example, 21 hydroxylase deficiency. This guideline writes as if the patient is 21 alpha hydroxylase deficiency, generally female, and infertility is possible in those population. So according to international consensus guideline, female gender assignment is advised. Okay, and always try to get surgery in infancy age group if the stage is more than 3. Okay, this is what recent guidelines tells. Okay, so this is about postnatal management. What do you do for prenatally? So prenatally, you have to give steroids. What steroids you give to the mother to prevent next baby virilization is dexamethasone. So when you have to start before 9 weeks. good effect is seen only before 9 weeks. So ideally, if the mother usually will get a result of pregnancy UPT test by 5 weeks, 6 weeks, so you have to start immediately. If the previous sibling is affected, so this pregnancy you have to start as soon as the pregnancy is confirmed, 5th week or 6th week, you have to start your dexamethasone. Okay, so and then you have to continue it as and when 9 to 12 weeks, you have to do chorionic villus sampling. So chorionic villus sampling, you have to search for this genetic testing and also do a sex identification. After taking the court permission, you have to identify the sex of the child. This is one exception where prenatal sex determination can be done if there is a suspected CAH. So if there is genetic mutation and the sex is also female, you continue the steroid. So if there is no genetic mutation in a female also, you stop the steroid. And if the if the genetic sex tells that it is a male baby and there is no genetic abnormality, you may stop the steroid. Okay. So that's how you can prevent female baby virilization. Okay. So inheritance you can discuss, autosomal recessive, 25% risk of recurrence. So this is how you have to do antenatal and prenatal management. So if they ask for management of CAH, you have to discuss about crisis. If they ask specifically about crisis, you discuss about the crisis. Then after crisis is settled, all these things you have to write. Okay. So management of chronic patient with CAH. Okay, hydrocortisone, fludrocortisone. Then when do you subject for surgery? What is your 17 OHP goal, and what is your frequent of following up the baby, and what are the investigations you plan in a 3-monthly visit or 12 to 30 monthly visit, and so after post-pivotal, what steroids you use, and how do you prevent prenatally, what steroids you give. Okay. So this is how you are to manage CAH. Okay. So I don't think Nelson describes so much about this. So it is very important that you just go through this article if it is given, CAH is given. If we ask for DSD, approach to DSD, then you write AIMS protocol. Okay, AIMS protocol flow chart and all. That is how workup for DSDs should be written. So you can read the AIMS protocol chapter if they specifically ask for approach to DSD. But if when they ask specifically how do you manage CAH and all, this article is very, very important. Okay. So I think it's too much of discussion today. Maybe in next class there is a online class I'll share you from ISPAE only. They are discussing about congenital hypothyroidism. So I will skip that congenital hypothyroidism. Neonatal cholestasis and NRP we can discuss one day. NRP and neonatal cholestasis. So those are the two things that are remaining, I think. Rest of the things we have discussed. I will share the today's material, whatever we have used. Okay. So anything you want to ask?